Today I'm going to talk about antibiotic stewardship in the pediatric hospital setting. I'm Joe Bertino. I'm the editor-in-chief of the Journal of Clinical Pharmacology. Our goals and objectives are to outline what is antibiotic stewardship, review CDC guidelines, discuss how this can be applied to the pediatric hospital setting, outline a general approach to antibiotic stewardship, show some examples from American pediatric hospitals, and discuss why this is important in Vietnam. So this is the CDC definition of antibiotic stewardship. Antibiotic stewardship is the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. Improving antibiotic prescribing and use is critical to effectively treat infections, protect patients from harm caused by unnecessary antibiotic use, and combat antibiotic resistance. Now, the CDC recognizes there is not one way to do antibiotic stewardship in all settings. And this is because medical decision making is very complex, and there's a variability in the size and the types of facilities and in the resources available. So let's talk about issues with antibiotic stewardship, and let's start out with stewardship programs in limited resource settings. Those institutions tend to have few infectious disease physicians. They don't have infection control, perhaps. They don't have pharmacists who are trained in infectious diseases. There's limited diagnostic and laboratory facilities. There's limited antibiotic use data. And there's limited bacterial susceptibility data. There's also weak data management systems, inexperience with data analysis, and limited availability of antibiotics. So in these very basic settings, these are some of the things that are suggested. Promote the creation of national committees, keeping in mind that one program is not necessarily good for all institutions. Next is to develop national and regional plans. Participate in antibiotic awareness campaigns. This is not just to prescribers, but to patients and the public. And adopt policies requiring prescriptions for antibiotic use in the outpatient setting. Now, for those institutions that are intermediate in terms of their level of care and their resources, the recommendations are to develop and ensure access to recommended formularies. A formulary is important. Next is create and promote adherence to evidence-based treatment guidelines. Promote diagnostic stewardship, that is, using diagnostic tests correctly and interpreting them correctly. And then support the inclusion of antibiotic stewardship program teaching during education and training. And this is for physicians, pharmacists, nurses, administrators, all individuals involved in the care of patients. Now, those institutions that have access to good resources, the recommendation is to enforce policies requiring prescriptions, track antibiotic use data and set national targets for improvement, measure antibiotic use and assess appropriate use, describe bacterial resistance patterns, and assess what causes inappropriate antibiotic use. So how do we build an ASP program? Well, you need to form an ASP committee. And this should include doctors, pharmacists, infection control people, microbiologists, nurses, and administrators. Start with one area of priority. For example, overuse of one antibiotic. Don't try to apply your ASP program to everything in the hospital. Start with one area. Develop and ensure appropriate policies are in place in the priority area. Educate the staff. Publicize the plan, that's very important, and then implement the plan. So these are some of the core elements of hospital antibiotic stewardship program. hospital leadership needs to be committed, and they need to commit human, financial, and information technology resources. Accountability. Appoint a leader or co-leaders, a physician and a pharmacist responsible for the management of the program and the outcomes. Pharmacy expertise. Appoint a pharmacist, ideally as the co-leader of the ASP, to help lead implementation efforts to improve antibiotic use. Action. Implement the interventions. Tracking. Monitor antibiotic prescribing. Monitor the impact of interventions. Next, reporting. Regularly report information on antibiotic use and bacterial resistance to prescribers, pharmacists, nurses, hospital leadership. And then education. Educate prescribers, pharmacists, nurses, patients' families about misuse of antibiotics and the consequences, and the potential for adverse reactions from antibiotics. So let me talk now about some of the challenges and examples of an ASP in the pediatric population. Let's start out with the critically ill children in the PICU and the NICU. Currently, there's little clinical data to guide daily ASP practice in these settings. For the neonates, there are very non-specific presentations of neonatal sepsis. There's very little published data on PICU, NICU children and ASPs. Laboratory tests such as procalcitonin may be less reliable in children, and then limits to blood volume for testing. All of these things make setting up an ASP practice and implementing it very difficult in critically ill children. Now I want to give you some examples in America of pediatric ASPs. First is the Children's Hospital of Colorado. What they found in the Children's Hospital when they set up an ASP program is that the traditional methods did not work. So they had to come up with a better method to have an impact. And so they developed something called the Handshake Method. That's a funny term, unusual term, but what it means is one-on-one discussion with clinicians about the use of antibiotics. So the ASP team reviews all antimicrobials daily. An ASP team member joins in patient care rounds to discuss ASP team recommendations. So this is this one-on-one discussion. And this method was shown to reduce antimicrobial use by 23% over 5 years, and also produced a savings of $12 million per year. Another hospital, the Texas Children's Hospital, which is a very large children's hospital. I don't think it's as large as Hanoi Children's, but it's pretty big. They had a program where they examined the use or overuse of piperacillin tazobactam. And these are some figures on piperacillin tazobactam justification for use, assessed from provider notes at 72 hours before they implemented an ASP. And you can see very low percentages in the chart in terms of why the child was getting the drug. What drug the child was getting? How about the specimen sensitivity? Is that information in the chart? Very rarely. Were the days of antibiotic therapy listed in the chart? No. And was the plan for antibiotic therapy listed? No. So these very low figures led them to develop an ASP system to try to improve this. And so at Texas Children's, they developed something called a bundle or a group of questions. And these were the questions that they asked. What was the indication for the antibiotic? What bacterial infection were you treating? In terms of the antibiotic used, is the dose, frequency appropriate? Are the children being monitored? And is there an opportunity to take a child at is receiving a very broad spectrum antibiotic and reduce it to a more narrow spectrum antibiotic. In terms of specimens, has the clinician reviewed the cultures that were obtained, and do the results of those cultures support the agent that the child is receiving, support the antibiotic they're receiving? And then the plan. The next physician that takes over the care of this child, will he know the current day of antibiotic therapy, when antibiotics were started, how many days of therapy are planned for this child, and what is the proposed stop date? I was always taught that when you prescribe antibiotics for someone, you should know how long you're going to treat the patient right from the beginning of therapy. So this is some data on comparison with ASP intervention using the bundle or the questions versus no ASP intervention. And what you can see is that when the bundle was used, the percentages of children that met the criteria were in the low to high 90% versus when the bundle was not used, where somewhere between mid-20s to around 60% reached the goal. So this turned out to be a pretty useful way to approach antibiotic stewardship in this pediatric hospital. I had shown you before the percentages for pip/tazo prior to ASP. These are the percentages after ASP, and you can see that 88% of the children had the indication noted in the chart. 83% was very clear what antibiotic they're receiving. 78%, the specimens and the sensitivity was reported in the chart. 64%, the planned duration of therapy was noted in the chart, and all data elements 60%. So this was really a pretty impressive increase once the ASP intervention occurred. So antimicrobial stewardship in pediatric patients, these are some of the important things to consider. First, educate the provider. And it's important to educate the providers that are already practicing and any new providers, new clinicians. Antibiotic restrictions may be effective at decreasing use of agents, may result in cost savings. This can be uncomfortable for those in the ASP program. Developing guidelines. Guidelines can be useful, but again, guidelines are just that. They're not rules. They're just guidelines. Next is prospective audit and feedback. Prospectively review antibiotic use and give the clinician feedback. And again, this gets back into handshake stewardship. One-on-one interaction of an ASP member with the prescribing physician. So now I want to talk a little bit about Vietnam and antibiotic stewardship. And those of you that may not know me, I've spent a lot of time in Vietnam since 2010, mostly in the north, Hanoi, Haiphong, some time in Da Nang, some time in Ho Chi Minh City, and visited many hospitals and spent some time in pediatric hospitals and pediatric wards. So I want to talk a little bit about that based on some of my experience. So in 2013, Vietnam became the first country in the World Health Organization Western Pacific region to approve a national action plan to combat antibiotic resistance. I was at that meeting in Hanoi, and it was a meeting where there were very differing opinions about how to do this or even whether to do it. The CDC works with Vietnam to improve the ability to track antimicrobial resistance. This is very important. There's a problem with antibiotic overuse in hospitals and in the community, and I'm sure you all know that. So this is some data from a study called REACT, and it is data on resistance of Klebsiella pneumoniae back in 2016-17. And what you can see is that resistance of Klebsiella pneumoniae to very commonly used drugs, third-generation cephalosporins, aminoglycosides, fluoroquinolones, chloramphenicol, was very, very high. Carbapenems, imipenem, and meropenem, very, very high. This is most likely due to overuse of these antibiotics. In terms of patient outcomes, what you can see on this slide is that 55% of patients that had a antibiotic-resistant Klebsiella pneumoniae resistant to colicitin failed therapy. 27% were discharged, 9% were still in treatment at the time of this study, and 9% we don't know what happened to those patients. But a 55% failure rate is very concerning. So these are some of my own observations from working in some of the public and private hospitals in northern Vietnam. First, antibiotics bought without prescriptions, and you all know about this. Pharmacies are not necessarily owned by fully trained pharmacists. That is a 5-year program. Resistance is promoted. Families go to the pharmacy. They get 2 to 3 antibiotics, just a few doses of each. Patients then present to the hospital with antibiotic-resistant bacteria. Very sick. Next is the difficulty in diagnosing pediatric infections, especially in the PICU and NICU. So children receive lots of empiric therapy. Next is systems that hold doctors liable for harm, even if they did the right thing. The patient has morbidity or mortality. Next is lack of enough supplies of antibiotics, and I will give you an example of that in a minute. And finally, treatment courses that are too long. So I want to review 2 cases with you. This is 2 cases that I saw. This first case is a 3-year-old child, a male, in the PICU. He arrived with trauma, motorbike accident. He was admitted to the PICU. During his PICU stay, he developed hospital-acquired pneumonia with Acinetobacter baumannii. It was sensitive to meropenem, resistant to colicitin and minocycline. And after 4 days of therapy, the hospital had no more meropenem and will not get any more until the end of the month. So how would we complete the treatment course in this child? Well, here are the problems. He had an antibiotic-resistant organism. He had limited availability of the proper antibiotic. And so we asked the question, where did all the meropenem go? What happened to the meropenem? This is a young child with a serious infection. Could an antibiotic stewardship program have reduced the overall use of meropenem in the hospital over time so that this boy could have received 10 days of treatment with the antibiotic? So how did we complete treatment? We treated him with ampicillin sulbactam. Sulbactam has good activity against Acinetobacter, but you need high doses of this antibiotic. And because it's combined with ampicillin, you're giving him high doses of ampicillin, so you need to be cautious about this. Fortunately, this boy recovered and was discharged to home after a total of 10 days of therapy. The second case was strep pneumoniae in a 5-year-old boy. He had a splenectomy for big spleen. He was not vaccinated with pneumococcal vaccine after surgery, and this boy developed strep pneumoniae blood-borne infection 4 times in 2 months after surgery. Each time he was treated with vancomycin, but the doses most likely were not high enough. He was receiving 10 milligrams per kilogram per dose, 4 doses per day, but he never really recovered very well. His 5th infection was strep pneumoniae meningitis. The organism had an MIC of greater than 1 microgram per mil to vancomycin. So the question is, could an ASP have prevented this by recommending appropriate dosing and serum concentration monitoring? It was available in the hospital where he was treated for the first 4 infections. So how are we going to treat this boy? This was the question that was posed to me. Vancomycin is a very big molecule, doesn't penetrate into the central nervous system well. The MIC of the organism was greater than 1 microgram per mil, and it's difficult to get sufficient drug into the CNS to treat an organism with this MIC. So we treated this boy with levofloxacin, 14 days of therapy, and then he received pneumococcal vaccine, and fortunately, he recovered. Could an ASP have intervened back when he got his first strep pneumoniae infection for proper use of vancomycin with proper monitoring? So my conclusions are that an ASP can be effective even in limited resource settings. There are many educational programs available online. I would refer you to the website cdc.gov. That's the United States Centers for Disease Control. There's also the Society for Infectious Diseases Pharmacists, sidp.org. You can find educational programs on those two sites. One-on-one discussion with prescriber, the handshake method, can be effective in reducing antibiotic use, but again, one system is not right for every institution. Everyone has to be involved. Pharmacists, physicians, nurses, administrators, microbiologists, infection control, and especially patients and their families. Patients and families need to be educated on misuse of antibiotics and the risks. An ASP can be done in the pediatric setting, modified to be appropriate for each institution. I just want to acknowledge some of the wonderful people that I've been able to work with in my time in Vietnam, my colleagues at Haiphong Children's Hospital, my colleagues at International Hospital in Haiphong City, and my colleagues at VinMec in Hanoi. And with that, if you have questions, you can email me. There's my email address. Happy to try to respond to them. So, come on.